we'll start now. The lecture today is about electrodiagnosis in anterior horn cell disorders. It's a very hot issue nowadays. We're going to talk why is it a hot issue now in Egypt these days, and of course all around the world. Let's start first by some just basic anatomy. What's a motor neuron? Well, it has different parts. It starts by the anterior horn cell body, and then the peripheral nerve, the neuromuscular junction, and the muscle fiber. And the part that we're going to be talking about today is the anterior horn cells. Generally, let's just agree on some basic rules. Generally, in any anterior horn cell disorder, what do I expect to find? In the nerve conduction studies, because this is a purely motor disorder, I might expect to see some small motor amplitude because we're getting axon loss, not demyelination, but because we're getting some axonal loss, we will not find any demyelination, and the sensory is usually normal. That is the basic template that we would expect to see in anterior horn cell disorders. About the EMG, the EMG is at rest. We can find positive sharp waves, fibrillations, fasciculations, or complex repetitive discharge. That is at rest. On mild action, we can find increased firing rate, broad and sometimes large polyphasic unstable motor unit potentials. I think you're all aware of the basic definitions, so I will not get into the definitions so that we can talk about more interesting stuff. But this is what I expect to see for the mild action. And for the maximum action, we expect to get reduced interference. Now, there are many types of anterior horn cell disorders. Sometimes when someone mentions an anterior horn cell disorder, you would only think of ALS or spinal muscle atrophy. No, there are many disorders, okay? So actually we have to think of a broader differential diagnosis. Of course, what's common is common, but we have to know that there are many disorders. The genetic testing and the genetic sequences have shown us how the wide variety of these disorders. If we talk now about the types of anterior horn cell disorders, it is spiked by the spinal muscle atrophy. Now, there are different types. Some references would say it's from 0 to 4, 0 being the intrauterine, the starts intrauterine, and some would say it's 1 to 4 categories. Let's go with the more common classification, which is 1 to 4. Types 1 and 2 would also labeled as Verding-Hoffmann disorder, would start right in infancy. And type 3, usually by adolescence, is the Kugelberg-Berander. These are like the older terminology. Now, of course, we're dropping names. In medicine, we're generally dropping names and using codes instead. But it's also useful to know these names because they are widely used. And the most common would be type 1. Now, this is the spinal muscle atrophy algorithm. And I got this algorithm from Professor Andoni Ortiz-Beria. He's really an expert on this. And we can see how we can proceed with the diagnosis of spinal muscle atrophy. Why is it important? Why is it a hot issue? Because now we have therapies. Previously, if a child was diagnosed with spinal muscle atrophy, he was destined for early death. Now, thanks to medicine, thanks to science, now we have medications that can treat these disorders, right? So it's now very important to know how to diagnose. Now we can see in the algorithm that he used is that if a child is suspected to have spinal muscle atrophy, he would first do a gene deletion test. And if there is a homozygous deletion for spinal muscle survival of motor neuron 1 gene, then the diagnosis is confirmed. That's it. Only a genetic testing. But if we do not have a genetic testing, or there's no homozygous deletion, which is very common, and especially like not all regions of the world would have this genetic testing, then we would have to proceed to EMG, nerve conduction studies, and CK levels. And then using these tests and using those algorithms, we can then proceed to the diagnosis of spinal muscle atrophy. Now we can see that even if the EMG is positive, they would do a survival of motor neuron 1 copy count. If there is 2 copies of survival motor neuron 1 gene, then they would diagnose that this is not a spinal muscle atrophy, right? They have to look to the other types that may mimic it, but not the spinal muscle atrophy. Why is this important? Because this would affect the type of medication that we're going to use. Because then some of the new medications will not really be of any help, because this child has 2 copies of survival of motor neuron gene. So it is important really to be aware that the gene deletion test, the SMN1 copy count, in addition to the EMG, is helpful, and we have to take the whole picture. Other types of anterior horn cell disorders is, we'll go briefly through the other types because they are rare. They're not common, but we have to be aware. The X-linked bulbospinal neuronopathy, also called Kennedy syndrome. What's special about it is that the patient would have facial fasciculations and the sensory nerve conduction studies would be abnormal, which is against, as I said, the rule of anterior horn cell disorders in general. But in this patient, I could expect to find sensory abnormalities. Another type that we have to really be aware of, the hereditary bulbar palsy. Is it common? No, it's not common. It is rare. Why should we know it? Because it's a treatable disorder. It's a treatable disorder, and this is like, as you can see, it's not a common thing in anterior horn cell diseases now. It's because caused by a mutation in riboflavin transporter gene, which is just treated by riboflavin, vitamin B. Vitamin B would help this condition. What's a sign that should really alert us to this condition is deafness. Now, this condition can be with or without deafness, but if we have deafness in a child with a bulbar palsy, then we should really think about this because he can only be treated by vitamin B. Other types of anterior horn disorders, the post-polio syndrome, we see this. It's very common. We can see it, of course, now the polio has been eradicated from Egypt, but we can see elderly individuals who had polio in their childhood. So a patient would come with increased weakness, which is, he doesn't know why his weakness increased. He knows he has polio, he might be limping and so forth, but for some reason, his weakness increased all over his body. Now, an important thing to note in this condition is that we're really looking for acute denervation, because a polio would cause neurogenic changes in all the body. Even if the patient thinks that his hands are free, they're fine, I only have a residual weakness in one limb, but if in any polio patient, I expect to see chronic neurogenic changes in all the body. How would I know if there is a post-polio syndrome? If we have active denervation. Another cause of anterior horn cell disorder is post-irradiation syndrome, hexosaminase deficiency. It's the acute infantilis Tay-Sachs disease, which is probably like very well known. It's due to intralysosomal GM1 ganglioside. Again, it's rare. Another type that may mimic anterior horn cell disorders, and sometimes it's considered a part of anterior cell disorder, is the HMN, hereditary motor neuropathy. Now, there is a little bit that puzzles about this disorder, because in some references, you would find that it is called hereditary motor neuropathy. And in other references, you'd find that it's called hereditary motor neuronopathy. So of course, if it's a neuronopathy, it's an anterior horn cell disorder. If it's a neuropathy, it's probably related to the axons. But anyway, we should look really for it. But why? The clinical picture is that the weakness would be predominantly distal. And it would have less active denervation. It's a much slower disease process than spinal muscle atrophy. So we'd expect that the changes would be predominantly distal, not proximal, and we really wouldn't find active denervation as much as SMA. Adult polyglucosan body disease, accumulation of polyglucosan in central and peripheral nervous system. Hopkins syndrome, an acute flaccid paralysis following an asthma attack. Cause, it's unknown, but it could be viral. Of course, this might be mixed up with AIDP, an acute flaccid paralysis. especially that in nerve conduction studies, the sensories could be normal in both conditions. Another syndrome we have to look for is focal monomilic amyotrophy. It's just a focal amyotrophy starting in one limb. It's usually in young adults, and the onset and progression are slow. We have to look for this because if I find it in one limb, I shouldn't really scare the patient. If I don't find it in any other limbs, I shouldn't really scare the patient. Oh, this is the beginning of ALS, or this is the beginning of type 4 SMA, and you're going to die within years. No, it can be just a focal monomilic amyotrophy. Now, if we go to the beast of anterior horn cell disorders, or the disorder that really entails the most research and the most care and the most everywhere, is amyotrophic lateral sclerosis. What are the criteria of LS? As you can see, the criteria of LS have been changing. First, when they started by L. Escorial in '94, and then changed to revised L. Escorial in 2000. What's the difference between revised L. Escorial and L. Escorial is that they added the category of clinically probable laboratory supported, which is basically if the EMG is positive. So they added this category to the L. Escorial. And then Awaji came in 2008, and Awaji would be like the biggest change from L. Escorial. How did it change? Is that it added the validity of fasciculations as an active denervation. Previously, active denervation would have only been stated if we found positive sharp waves and denervation potentials. But in Awaji, the scientists said that, wait a minute, fasciculations are the earliest sign. And if we disregard it, then we're really delaying the prescription of treatment for these patients. So they started respecting the fasciculation potentials. Another thing is that they equalized, this is the major step, is that they equalized the significance of positive findings by EMG and clinical findings. L. Escorial and revised L. Escorial would state clinical probable and possible only based on clinical findings. But in Awaji said, even if I can't see it clinically, but it's there by EMG and nerve conductions, then it's counted. I have to respect it. What did the modified Awaji in 2016 change? They changed that, wait a minute, we had this category, of course, Awaji now, after respecting the EMG diagnosis, they canceled the clinically probable and laboratory supported category, because now everything is laboratory supported, so they canceled this category. But then they found that if you cancel this category, the patient is downgraded from probable to possible, and he's not treated. So another modification was suggested is that, okay, we'll return this category again, just to increase the chances of patients of getting treatment. And then now we have a new proposed criteria. I'm not really sure what they're going to call it. It was the panel, they met in Gold Coast, Australia, so maybe it's going to be called Gold Coast criteria, and we're going to talk about it later, because this criteria really changed everything. Now, the ALS Awaji criteria, let's start from this point. There is no need to go back to ALS Escorial now. So the Awaji criteria, they stated that we have to find the presence of lower motor neuron degeneration by clinical, electrophysiological, or neuropathological examination. Previously, it was only clinical. But for upper motor neuron degeneration, the presence is by clinical examination only. And then the symptoms and signs must be progressive. They have to be progressive. I can document in the disease process. And this is, I would only respect it in the absence of, again, in the absence of any electrophysiological or pathological evidence of any other disease, okay? And the neuroimaging evidence of any other disease. So I can only respect category A which is the presence of lower motor, upper motor neuron, and progress in symptoms, if I cannot explain the disease process by any other pathology. The Awaji classification, definite ALS by lower motor neuron and upper motor neuron dysfunction in at least 3 regions. The probable in 2 lesions, but some upper motor neuron must be rostral to the lower motor neuron signs, and the possible by lower motor and upper motor in only 1 region, or upper motor neuron signs in 2 regions, or lower motor neuron signs are rostral to the upper motor neuron signs. So these are the 3 categories of Awaji without adding the modified Awaji because it's not accepted by everyone. Again, to remind you, what's the difference between Awaji and revised LS Corial is that they omitted the laboratory supported category. And then in 2020, a consensus conference sponsored by the International Federation of Clinical Neurophysiology, the World Federation of Neurology, the ALS Association, the Motor Neuron Disease Association, convened in 2019 at Gold Coast, Australia. And they decided, you know what, okay, the criteria we have, it could be very specific, but it's not sensitive. So many patients would die from ALS and they only fit the possible criteria, okay? And sometimes if there is only possible, they are not offered medication. So they said, we really have to change this. Because why? We want to increase the sensitivity so that we can offer the treatment option for patients who would have no hope. What's the new criteria for whatever they're going to call it, Schaffner criteria or Gold Coast criteria or whatever, is first, we have to find progressive motor impairment documented by history or repeated clinical assessment, preceded by normal motor function. So I know that this patient started from being normal and then he had a progressive motor impairment. Second thing, presence of upper and lower motor neuron dysfunction in at least 1 body region. You can see how they changed that. In only 1 body region, with upper and lower motor neuron dysfunction noted in the same body region if only 1 body region is involved. They have to be present together in the same region. Or a lower motor neuron dysfunction in at least 2 body regions. So what do I need? An upper motor plus lower motor in 1 region, or lower motor neuron dysfunction only in at least 2 body regions. And the investigations excluding any other disease process. We have to note that all 3 criteria must be present, and we note that they canceled categorization. There will not be any more probable, possible, definite, that's it, it's gone, it's gone. Now these criteria, they are waiting for more validation and for more application in the clinical setting, but I can see that this is the one that's going to be used because of the patients that die from ALS without being ever improbable or the definite categories. Now, how do I say that a region, a body region, is affected by EMG in ALS patients? First, for the cervical and the lumbar regions, I must find the active and chronic denervation in 2 muscles, in at least 2 muscles, supplied by 2 different routes and 2 different nerves, okay? They can be in 1 limb. So for example, I can take the FDI on the right hand and the biceps on the left hand. That's okay. But I cannot take, for example, the EIP, the extensor indices proprius in 1 hand and the triceps in the same, in 1 limb and the triceps in the same limb because there's both supplied by the radial nerve, okay? So we just make sure that different nerves, different routes. And for the cranial and thoracic regions, I only want to see these findings in 1 muscle so that I can say it's positive. So for the upper and lower limbs, they have to be present in 2 muscles, supplied by 2 different routes and 2 different nerves. But for the cranial and thoracic, only 1 positive muscle is enough. How do I say that a region is positive? By finding the active innervation of positive sharp waves, fibrillation potentials, or fasciculations. This, if I find any of these, not all three, just any of these, then I find that this is, I can say that we have active denervation here. Please note that chronic complex repetitive discharges do not constitute active denervation. And on action, I would find broad, reduced motor unit potentials. It could be large amplitude if I have a decent re-innervation. I expect to find increased firing rate, although this could be absent because the patient has also an upper motor neuron lesion, reduced interference, or unstable motor unit potentials. So for any muscle to be positive, I must find active denervation and chronic denervation. I'm stating this because when you're working in real life, sometimes it's very exhausting looking for active denervation. It's very exhausting for the patient, it's very painful, and it's very exhausting for the physician. But you cannot say that this region would fulfill the criteria of ALS if you do not find both active and chronic denervation in the same muscle. What's an unstable motor unit potential? This is another term that's now accepted as a sign of chronic denervation if we have active denervation with it. It's a motor unit instability. It's basically that if I find a single motor unit potential and if I roster it by a trigger delay line so that I can see the different types, just like it would give I'm going to show you a picture now. We'd find that the same firing, the repetitive firing of the same motor unit, there is a change in its morphology, okay, blocking, as well as enhanced jitter, or we call it jiggle. I may have to change the filters a little bit so that I can see it clearly. And this is an example of what an unstable motor unit potential would look like. Okay, you can see that with the trigger delay line, there is an increased jitter, or we call it jiggle, and the different firing, it's not the same. Because some parts of the motor units are blocked. So the different firings are not the same. What do I expect to find in nerve conduction studies in ALS? As I mentioned, the template that I mentioned in the first slide, this is what applies to all ALS, to any anterior horn cell disorder. But I would have to note something, that they allowed for a mildly reduced synapse sensory nerve action potentials, right? In the presence of neuropathy of identified etiology. For example, it's very common that you would find an individual with long-standing diabetes. I cannot say because, well, his sensories are affected that he doesn't have ALS. No, you should really look at the patient as a whole, right? The conduction velocities, they can be reduced more than 75% of lower limit of normal, because this is what you would expect to see in axonal pathologies. However, if the conduction velocity is reduced to less than 75 or 70%, then I must really think that this patient might have some sort of demyelinating neuropathy, which is like good news for him, right? And the F wave latency less than 130% of the upper limit of normal. Of course, in the absence of conduction block,
I think there is a technical issue. We are waiting for Dr. lamiaa once more to reconnect with us.
I think that there is a problem in the net connection.
But I think the connection is coming back.
Inshallah.
In the meantime, we can answer the questions.
There is no lamiaa for answering.
You can help in the answer of the question. We'll try to contact Dr.
She's trying to attend, I think, because she's still online, but no.
Dr. lamiaa, bye. Yes, she's wonderful.
Yes,
Dr.
yes.
Sausan said it's a wonderful lecture. Yes, it's wonderful. This is usually the custom of Dr. lamiaa Afifi. She's always perfect in
she's now
presenting the lectures.
Lamia.
Connection,
Lamia.
Share your screen, Dr. Lamia.
Okay, now
It's
can you hear me?
Can you share the screen?
Okay.
Yeah, we can hear you very well.
Okay. So did you hear the slide? Well, it got disconnected.
The previous one?
Yes. The previous, please, Dr. Lamia.
Here?
Yes, yes,
this one.
Okay, you can begin it. You can begin it because it's important, Dr. Lamia. It is. It's a very rich slide. It's a very rich slide.
Thank you very much. Well, for the nerve conduction studies in ALS, basically, we have to exclude other diseases. This is the most important value for nerve conduction studies in ALS, is exclude other diseases. Because we're having a motor unit loss, I would expect to see a small amplitude. I can see mildly reduced sensory nerve action potentials in the presence of neuropathy of identified etiology. So for example, a patient who has long-standing diabetes, his sensors might be affected, but that would not disagree with the diagnosis of ALS if I find the other signs are present. The motor conduction velocities is more than 75% of normal, and the F wave less than 130% of normal. There is no conduction block, there is no temporal dispersion. Why? Because if I find anything against this we would think about demyelinating polyneuropathy. The Awaji and the 2020 criteria position on electrodiagnosis for diagnosis of upper motor neuron lesions. They stated that neurophysiological testing can be helpful to diagnose upper motor neuron lesions. However, this must be diagnosed clinically. Okay, this is an important point. So neurophysiology, if for lower motor neuron lesions, it can substitute or clinical testing, but in upper motor neuron lesions, no, these signs must be present clinically. How can I use neurophysiological testing to help with diagnosis of upper motor neuron lesions? Transcranial motor stimulation. Transcranial motor stimulation is basically what do I expect to see is that an increased central motor conduction time. If I stimulate at the periphery, at the roots, and then over the skull, there would be an increased central motor conduction time. This is a way of diagnosing upper motor neuron lesions. I can also find increased absolute latency to a distal muscle if I know that the distal motor conduction slowing is excluded. And sometimes even in patients with bulbar onset, an absent response of transcranial stimulation to a limb is supportive of upper motor neuron lesion. Now, another new technique, which is very important, I would like really to talk about it specifically, is the triple stimulation technique. Triple stimulation technique, magnetic stimulation, I'm using a stimulation at three sites, over the roots and distally, like for example, over the wrist. They are stimulated in a sequence. Why? Because to increase the synchronization of a motor unit volley. So first the one over the skull, then over the wrist to allow collision, and then the one over the roots, because this way we can improve vision, and then I can really get an accurate assessment of the motor units that are still functioning. This is, we talked about this. Another promising is the cutaneous silent period. Cutaneous silent period is basically having a sensory stimulation, a little bit of a high impulse, and then and we're recording from over a distal muscle that's in continued contraction. They found that if I stimulate the sensory supply of that dermatome, and then there would be a brief pause in the contraction in that muscle. Now, the brief pause we measure its onset latency, its duration, and even its presence if it's there. The cutaneous silent period is a promising neurophysiological technique. Many uses for it now, and now there is a new paper which is like really, it caught the attention of the ALS community, is that they found that the cutaneous silent period onset was found to be delayed in ALS patients, and progressive muscle atrophy, even those progressive muscle atrophy patients who didn't have upper motor neuron signs clinically. And this is thought that cutaneous silent period might be a sensitive test to detect dysfunction of the corticospinal tracts. When would I think that the patient is having possible ALS? So if I find some findings in the EMG and the nerve conduction studies, this does not exclude ALS. It might be found, it's not common, but we really, I'm just going to talk about 2 or 3 points here, which is that I can find an up to number 7, up to this, these are the Awaji criteria, by the way, up to 50% decrement in motor conduction velocity below established normal values, if the compound muscle action potential is below 10% of normal. So you can remember that I said in the rules, the conduction velocity should not be less than 75% of normal. However, if I find that the amplitude is so small, and this is, we commonly see this in ALS, we can allow up to 50% decrement in motor conduction velocity, and up to 20% decrement on repeat stimulation. So this is very important. It's because of the axonal degeneration and of course the affection of muscular junction. So up to 20% decrement of nerve stimulation, it could go with ALS. It does not exclude ALS. Now, what are some signs which say that the patient does not have ALS? Of course, more than 20% decrement stimulation, conduction block. Here, the reduction of conduction velocities values below 30% if we have a normal compound muscle action potential, or more than 10% of the compound muscle action potential. And the sensory action potentials, I would allow up to 20% delay reduction in amplitude. When can I find sensory abnormalities in anterior horn cell disorders, especially in ALS, in anterior horn cell disorders? If we have a confounding entrapment, or the patient has a reasonable cause for a coexisting neuropathy. The most common, of course, is diabetic, but there could be many other causes, right? Entrapment, I commonly see this very much in ulnar nerve, sometimes because of the marked wasting. The ulnar nerve, we'd find that there is an ulnar neuropathy across the elbow in ALS patients. And you would find that there is a small sensory amplitude from the 5th digit. But because of the marked wasting, remember, there's very commonly an ulnar nerve entrapment across the elbow. And other causes is the X-linked bulbospinal muscle atrophy, the Kennedy disease, and the adult polyglucosan body disease. Now, some interesting aspects about ALS is that the ALS hand, the split hand. It was found that in patients with ALS, if I compare the amplitude of abductor polishes previous to abductor digiti minimi, that the ratio would be less than 0.6. And the ratio of the first dorsal interosseous to the abductor digiti minimi, the ratio would be 0.9. So if I find any of these, I might think that this patient has ALS. It's some sort of selective degeneration, so the lateral part of the hand is much more wasted than the medial part of the hand. If both ratios are abnormal, this is highly suggestive of ALS. So a study was conducted that tested ALS patients with normals or patients who has cervical spondylosis and neuropathy, and you can see that nearly none of the other diagnoses had the combined the decreased ratio of the APP and the FDI. There is another thing called the split hand index, which was suggested that if I this formula, if the APP CMAP times the FDI CMAP divided by the ADM CMAP. If I get a number that's less than 5.2, this would support the diagnosis of ALS, right? The split hand index. Another thing that was devised called the neurophysiology index. Why should I respect it? Because Swash and De Cavallo are some of the foremost pioneers in ALS, and really should really respect any article they should publish about ALS. And they found that, wait a minute, if we take the neurophysiology index, which is the CMAP size divided by latency times the F-wave persistence, we get something which we would call the neurophysiology index. Why is this important? Because it would allow the objective follow-up of patients. Objective follow-up of patients. Sometimes we really need this, especially now that there are so many trials for different indications, and the pharmaceutical companies would really want more objective criteria to test their potential drugs. So the neurophysiology index could be very helpful in following up the different nerves of that patient. Another thing is the motor unit estimation. Now, this is a little bit of a complicated technique. You must usually have the software to allow it. It is basically a technique which would allow us to have, as its name implies, the estimation of the motor unit numbers in a muscle. Now, there are different ways to count the immune, but let's say that the most commonly used are the multiple point stimulation and the Munix. It's the motor unit number index. The Munix, of course, needs some very dedicated software for this. Why is it important to get the to know the number of motor unit estimation? As I said again, like for the neurophysiology index, for objective follow-up, especially in research. Ultrasound, does it have a role? Now there's more talk about the use of ultrasound to diagnose ALS. It's basically the most common thing is that, they would say that it's helpful for detecting fasciculations. Just by ultrasound, you can see that a muscle is fasciculating. There are other things, is that testing the muscle echo intensity to know how much fibrosis there is, the cross-sectional area of there. So if it's really declining because of the motor, because of the axonal degeneration. However, we know that the findings may not correlate well to the measures of functional decline, and it's really of validation in multi-center studies before you can say that ultrasound is really helpful in diagnosis of ALS. But we should know about it. And the last thing is that I want you to remember that neurophysiology cannot be used solely alone to diagnose ALS. It only works in conjunction with clinical examination, right? We only can use it in conjunction with the clinical examination. Thank you very much, and I hope I didn't go too long. Thank you.